As a result, your mouth is going to open. But it is not done only solely by the lateral pterygoid. There are also accessory muscles of mastication, like anterior belly of digastric, the mylohyoid muscle, and the genohyoid muscle. So mylohyoid, genohyoid, and anterior belly of digastric are accessory muscles which are going to pull the mandible down and will assist in opening of the mouth. The closing of the mouth is done by medial pterygoid, temporalis, and masseter. So medial pterygoid, temporalis, masseter pull the mandible up, elevation and backward retraction, causing the mouth to close. This is again a diagram showing you the different parts, and you can read through it. I will not go into detail of this. It's already written how this is going to open or close. The accessory muscles we will show you in a minute. One is the mylohyoid muscle, which is forming the floor of the mouth. Then you have the hyoglossus behind it. You have the anterior belly of digastric, stylohyoid, and you can see the nerves which are coming and supplying these muscles. Similarly, these muscles are shown here. So this is the mylohyoid muscle. This is the hyoglossus behind it, anterior belly of digastric. And then these are the infrahyoid muscles which are shown below. Again, these are just the diagrams showing you the accessory muscles of mastication. Yes?
If there was an upper motor neuron injury to the mandibular nerve, would the mouth
To the
mandibular nerve, would the mouth be opened or closed?
There could not be an upper motor neuron lesion to the mandibular nerve. It could be to the motor nucleus of the trigeminal nerve. This is what you are saying. Yes.
Would the mouth be open or closed?
Yeah. So the mandibular nerve also get the bilateral supply. So the motor nucleus of trigeminal is going to get bilateral supply. So you would not really get anything with the upper motor neuron type. Okay. So this is a diagram showing you that while you're eating or masticating, there is an elliptical cycle. So you open, close, and you move side to side. So there is an elliptical cycle of movement of the mandible. So there are certain movements in the mandible. One is depression, the other is elevation, then there is protraction, and then there is retraction and side to side movement. And do not consider the two temporomandibular joints separately. They would work together. So for opening, both mandibular TMJs will work together to open the mouth. Similarly, closing, both TMJs are going to work together. Protraction, retraction, and side to side movement, they are all going to happen. So these are the movements at the TMJ. Elevation, depression, protraction, retraction, and side to side movement. Now, elevation, we said the primary function in terms of elevation, closing the mouth, is by masseter, medial pterygoid, and temporalis. For opening the mouth, the major function is lateral pterygoid, and then there are accessory muscles of mastication like mylohyoid, digastric, anterior belly, and the genohyoid muscle. So these are the three muscles which are opening the mouth. Now we are coming on with the protraction and retraction. Medial and lateral pterygoid both are important in protraction. So protraction, you are protracting. Both medial and lateral pterygoid are important protractors of the mandible. Retraction, the major muscle is temporalis. So temporalis is the major retractor of the mandible because it's coming from the back. So retraction is temporalis, protraction is lateral and medial pterygoid. And side-to-side movement is alternate contraction of median and lateral pterygoid. So one side would contract, one side would relax. So side-to-side movement is by the alternate contraction of median and lateral pterygoid muscle. So these are the principal muscles supplied by the trigeminal nerve. Digastric anterior belly is supplied by the nerve to mylohyoid. Mylohyoid muscle is supplied by the mylohyoid muscle nerve, and genohyoid is by some C1. And if we look at the function, elevation is done by masseter, and it has a very small function in protraction, retraction, in side-to-side movement. Elevation is also done by temporalis, and it is also doing retraction. So major function here is retraction and elevation. Medial pterygoid, elevation and protraction are the major function, and then it works with the lateral pterygoid for side-to-side movements. Depression is lateral pterygoid, and protraction is its major function, and then it works with the medial pterygoid for side-to-side. So this is alternate contraction. So that's why it is written unilateral. So you have one side medial pterygoid contracting, the other side lateral pterygoid contracting. So alternate contraction will result in side-to-side movement. Accessory muscles we have written that depress the mandible when the hyoid bone is fixed. We are coming to some syndromes. There is a temporomandibular syndrome, which is basically inflammation of the temporomandibular joint, and this inflammation of the temporomandibular joint will result in a referred pain over the face, the jaw, and over the temple. So you can have the inflammation of the TMJ referred on the face and as a headache on the temporal side. So this is called the temporomandibular joint syndrome. You can have the dislocation. We said that if you have excessive opening of the mouth, this can lead to the anterior dislocation. That is the most common type of dislocation which you can have. And if you want to close this, there is a close reduction which is achieved under sedation by holding the mandible firmly between the thumbs of the lower molars and yanking it upwards, forward and downwards to drive the condyles back past the articular tubercle into the mandibular fossa. And dentillous mandible we have already talked about. When you have loose teeth in the older patient, there is resorption of the mandibular bone. So that is called the edentulous mandible. So we'll have a break for 10 minutes.